How you guys doing? I'm Andrew Beck, one of the fellows in medical education from Brown University. And this is Fred Verone. He's one of our graduating PGY4s. And then with us, we also have Chris Merritt, who's the program director for the Medical Education Fellowship, and Meredith Horton, who is our PGY3 collaborator on the project as well. Before we go any further, there is going to be a group discussion here, so if any of you want to come and sit closer together, feel free. That said, if this is the amount of attendees we have in the room, everyone should be able to hear each other just fine. So you're, up to you guys. So, but we're here today to present Working with Challenging Learners in Clinical Emergency Medicine. This is a workshop to help offer some tips and tricks for how to best or how to better work with learners that may be less than straightforward. So first of all, in terms of conflict of interest, we have no external funding, no grant sources, and no one has any conflicts to disclose. So today we're going to talk about defining what a challenging learner is, how to characterize them phenotypically, strategies for working with them by phenotype, and we'll do a demonstration, and we have several individual phenotypes prepared for us to watch videos of and then discuss how to work with, and then we'll wrap up. So in terms of the objectives for this didactic today, identifying and classifying challenging learners in clinical emergency medicine settings is number one. Implement teaching and debriefing strategies using 6 unique learner phenotypes. Demonstrate teaching techniques in a simulated clinical scenario, and develop a safe environment for all teaching interactions, are what we'd like to accomplish today. So the first task is defining what a challenging learner is, and I want everyone to take a moment and dispel whatever you may have in your head about what a difficult learner might be. We all have some preconceived notion as to who this learner is and how they behave, but this isn't always the misbehaving learner, which is often what we think of in our minds when we think of a learner who might be less than straightforward. It's not always someone who's disrespectful. It might be someone who is disengaged or simply quiet or not interacting. So take a moment and just kind of dispel whatever preconceived notions about challenging learners you may have, and we'll talk a little bit more about individual phenotypes of them. First, we do want to say a special thank you before we get any further along here to the authors that we have listed here. As we did a very broad literature review of over 30 papers when preparing this discussion, but we found this paper, which had also done a lot of review of existing simulation literature, to be very helpful, and we thought that it merited special recognition. So thank you to Grant Robinson, Katina, Beck, and Chang, if any of you are in the room or watching. Okay, so as we get into talking about what might be a challenging learner situation, remember that it's not always the learner, and that sometimes it's the environment, because even a very smart, very capable, very gifted person might perform very poorly if you put them in an environment that isn't appropriately suited or conducive to learning or to performance. And this is a common problem that we have in emergency medicine and in medicine in general. Think of the brilliant student who winds up being intimidated by a surgeon in the operating room and therefore doesn't answer, doesn't perform, looks quiet, looks as though they're not doing a correct job. So just be mindful that the characteristics that we're going to talk about today, while they relate to the learner, the environment can sometimes be just as much of an influence on what seems like a challenging learner as the learner himself or herself. So beginning with some phenotypes of challenging learners, we have quiet learners, or learners who may be reluctant or reticent to participate. There can be many personal reasons for this, as well as systemic reasons. They might be disengaged or disinterested as well, again, for both personal and or professional circumstantial reasons. You never know whose mom might be in the hospital, and they might be having a lot of other thoughts on their mind while they're sitting there trying to work with you in a classroom situation. We have domineering learners, both those that have poor insight and knowledge into their performance, and those that might have good insight or knowledge into what's actually going on. But either way, they are going to run away with the conversation, steamroll others, or create a challenge for those around them. We have emotionally reactive learners, and this could be for a number of reasons as well, both personal and situational. And we have defensive learners. So those are the 6 phenotypes that we're going to go over today. The quiet, the domineering with good insight and poor insight, the reticent or reluctant to participate, the emotionally reactive, and the defensive learner. Okay, so Dr. Verone is going to talk about some communication strategies within individual learners. We aren't going to talk too much about the situation as much as we are the learners themselves.
Thank you, Dr. Beck. All right, so before we sort of get into the meat of this presentation and the workshop that we're going to be doing, we're just going to touch on some of the tools that we will be using. When it comes to teaching in general, we've got proactive strategies and we've got reactive strategies, and just kind of coming down our list here, for a proactive, we have pre-briefing and body language, but what we're really going to focus on today is reactive strategies, mainly communication strategies to use in the moment. And we'll go to our next slide there, and this is the handout that you've received, so I won't spend too much time on this, but this will be the tool that we use for our actual workshop. And what I'm going to get into is each of these sort of communication strategies that have been described in the literature that we felt were the most relevant and the most useful to actually use at your bedside teaching. We'll go through each of them briefly. So starting with normalization. As a tool, this is a way of reminding learners that struggles, challenges, even successes are a normal part of their job and of their training. Validation, acknowledging feelings of frustration, acknowledging feelings of anger, and letting people know that mistakes are okay and that they're going to happen. Paraphrasing, or using a facilitator to summarize an encounter in a situation, putting things into other words that might help people understand things. Broadening or extending the example to involve other learners or to bring in other relevant outside information. Naming the dynamic, technique for, previewing, technique for moving discussion beyond the point of fixation, and so this might involve setting up expectations before delving into your teaching. The next one will be naming the dynamic, which is highlighting the challenge or sticking point, sort of just calling out what the problem seems to be and bringing it out into the open for discussion. And finally, generalization, or applying learning points or principles from one situation to another to permit knowledge extension. And that's a very brief overview of all that, because I really want to just get into the videos that we've shot for this. So we scripted these videos, and I want everyone to sort of put themselves in the shoes of who the teacher in the situation is. The thought behind this was whether it's you as an attending physician with your residents, a senior resident with a junior resident, or a medical student who's rotating, that we wanted to sort of put these situations out there and be able to kind of delve into how to address bedside teaching in the moment. When you have a difficult learner, as we're calling them, on shift, and you don't want to be, you want to have your toolkit ready to go at the bedside where the best teaching happens. But I think too often we kind of just put things to the side, and we don't get the best teaching done that we can. So we're going to go into these videos. These were scripted and shot at the Lifespan Sim Center for the most part, involving all of the collaborators on the project. So we're going to start with the first one, which is going to be an example with two different types of students, a domineering learner with good insight, as well as a quiet learner.
So again, the whole idea here is to put yourselves in the shoes of the teacher or the person who is going to have to work with these particular learners in a clinical situation, and think about how you would use the tips on the tool sheet that we handed out to either diffuse a situation, improve the learning environment, or altogether make for a more collaborative, healthy learning situation. So let's watch this first one as an example, and then we'll work through it together. And after that, we have 4 more examples that we'll look at as a group and talk about the techniques and what sorts of things we can say to best work with these individual learners.
All right, team, let's take a few minutes and debrief that case. There was a lot going on, and there were some challenging aspects to it. I know you're both first years, and I'm not sure if you've seen cases like this before, but I just wanted to ask, what was your initial reaction?
Yeah, I've never seen a STEMI before. I've seen a lot of patients with chest pain, but this was different.
Yeah. These cases can be, they can be overwhelming at times, but it's really, timely identification and the correct management can really save a patient's life. So let's talk about the case in more detail. Does anyone want to summarize it for me?
Yeah, sure. So a middle-aged man came in with chest pain, was found to have an ST elevation MI, and then he was taken to the cath lab.
Yeah, that's a pretty concise summary. What were your initial thoughts on EKG? Anybody?
I mean, there's like obvious ST elevations in the anterolateral leads with reciprocal depressions. I can see them from here.
Yeah, I think we can agree this was one of those textbook EKGs that were really hard to miss. It's classic STEMI. So would either one of you like to talk me through your initial management? What's your approach to treating a patient with a STEMI?
Yeah, so I always start with ABCs, IV O2 monitor, EKG, and then get cardiology involved early. You want to give aspirin because it's life-saving, an antiplatelet agent, and then heparin. And it's always really important to apply defibrillation pads early in case the patient decompensates into an arrhythmia.
That, thinking about defibrillation pads is a great idea because these patients can decompensate quickly. So that's a good advanced planning. Do either one of you have anything else to add?
I like to use the STEMI care set. It's really helpful to have everything in one place so you can take care of sick patients really efficiently.
That's a great suggestion.
So, why don't we just open it up?
Yeah.
Right? First of all, thank you for suspending disbelief in that was like the oldest intern ever. What are some initial reactions from folks in the audience about both the types of learners that are there and then how you as the bedside teacher might sort of address each of those learner types?
Well, I mean, obviously you have one quiet learner and one learner who's domineering and kind of taking over the whole conversation. And I think one thing that I notice that and I have to do is when I notice when somebody's overtaking the conversation, rather than saying, does anybody have any ideas? Sometimes you have to actually just call the quiet person out, and they're just afraid to speak up because maybe the other person is domineering, and it may not be that they're actually truly a quiet learner, they just are more quiet than the domineering one.
Yeah, absolutely. And what do we know about that quiet learner in this scenario? Like, how much do we know about them? Not much at all, right? Like almost nothing. Are they quiet because they don't know what's going on? Are they quiet because they are intimidated by the other person? What are some of the other techniques that folks, so sort of directed questioning is really, really going to be helpful in this case, right? To both sort of diagnose our learner. Are there other techniques that folks can think of or other situations that are similar to this that you might bring to bear? That's a silly question, maybe.
Yeah, you could almost, he tried to do it. He was making eye contact with the quiet learner, and the quiet learner was then giving that eye contact to the domineering learner. So, but sometimes that'll work if you just focus on, the quiet area of the room or the quiet learner, and then don't open up for, does anyone else, just say, do you have?
Yeah, and I think that sort of everything you can do to both normalize the situation, right? Sort of like I think the teacher in this situation did a pretty good job of trying to create a safe environment for learning. But there are certainly specific steps that we might take in this situation, both to understand what our learner understands and then to direct, based on what we learn, to direct questions or to what the perceived level of understanding is.
Microphone's right. I think the instructor was trying to do the right thing, what we perceive as the right thing, is like opening it to everybody, but they're not taking an active step of recognizing that that's not the right forum. Right? As a call to learner, give the quiet person a chance to shine. Maybe not call them out directly, but kind of give them the spotlight and the microphone, give them their chance. So I think the instructor was trying to do the right thing, but was failing to do the right thing because they didn't recognize their own shortcomings or their abilities as an instructor.
I think the other thing that you can do sometimes as an instructor is when the domineering learner has brought something up, ask the quiet learner an expounding point on it. So that kind of gets a little bit to their medical knowledge. Like when the domineering person said, talked about the order set, you can actually ask the quiet learner if they know what's in the order set or not. And you can ask it in such a way that it makes it's safe. It's like, do you know what's in it? Okay, you don't? Well, what's in it? And then you can talk about what's in it. So that can get them into the conversation in kind of a safe way and assess their knowledge too.
Right. Open the door in a very sort of safe feeling way, right? Like not like, what do you tell me everything you know about STEMIs, but have you seen this order set? Have you used it? What are the things that are in it? I think those are really helpful.
And I'll just point out that what we just did right there, without even saying it directly, is if you look at your toolkit there and you look at the quiet reticent, we hit on a lot of the points here that where you see that yellow circle with the Q in it, for that learner type, for the quiet reticent, we use validation, we use broadening, we talked about naming the dynamic, just, pointing out, hey, you're quiet today, is everything okay? So that's the way we want to use this toolkit. We've got 4 more of these videos, and, we're all doing it already, so.
Interestingly, though, we talked a lot about working and helping the quiet learner here. We didn't really talk that much as a group about what to do with the domineering learner. Now, in this particular case, our domineering learner tends to be a very calm individual, as it were. But in some cases, a domineering learner can be a lot, much more so than this. I personally tend to trend towards that when I'm a learner. I often over-participate, and I know that, and I have to rein myself in. But if this were a different situation, there's a chance that I personally could have steamrolled that entire interaction. And it's just these are personality characteristics, and this is what happens. So, how would we sit back and look at this and say, we talked a lot about the quiet learner. What could we do to manage the domineering learner? Because there are 2 types of domineering learners. There's those who actually have a decent amount of medical knowledge and even awareness that they might be doing it, which is pretty much demonstrated here. She got everything right. And then there are some who may just steamroll but be completely, totally off base with both their medical knowledge and their personality and these other characteristics. So you don't necessarily want to shut down the domineering learner and make that person, in this case anyway, feel as though they shouldn't be participating or don't know what's going on, because those are positive characteristics that you can just rein in and help manage. But at the same time, when you put a domineering learner in the mix with quiet learners or disengaged learners, the domineering learner might do just fine, but you really have no concept as to whether the other 2 learners are really getting what's going on at all. So how could we help taper the domineering learner without shutting that person down in this situation?
I think you just have to gently help them with some self-reflection of I really appreciate your contributions. I'd like to hear what the rest of the team has to say. But we don't totally shut them down.
Right. So what you just described there is broadening. So which is a good technique to use in that situation to help spread the contribution to other persons. Because I don't think anyone would be offended or hurt by what you just said. It just is an inclusive statement and a means of being able to say, okay, that's great. What other thoughts do we have from other parties in the group about this?
And we're definitely going to have some chances to practice some of that.
Yeah. All right. Yep. So we'll move on to the next one. Yeah, working on. There we go. Okay. So we've already discussed this together. No need to go further. So let's take a look at our next video. What'd you hit? Just restart it from the same slide.
Good morning, everybody. Thanks for coming to Morning Report. I thought today we'd go over the primary survey of a trauma patient, seeing that this is a new month in the ED. How does that sound to everybody?
Sounds great.
Awesome. So let's start with the case. We have a 58-year-old gentleman coming into the emergency department, fell off a ladder. What's our initial management going to be?
Start with A. I would assess the patient's airway, make sure that that's stable, make sure his airway's okay.
Great. And how do we accomplish that?
Well, generally I would look at it, see if there's anything that's blocking it up, listen, see if he's talking in full sentences.
Excellent. And then what's our next step going to be?
I'd go to B with breathing. I would assess breath sounds, feel for crepitus.
Absolutely. And let's say you ran into a problem there. You felt crepitus. What would our next step be?
Well, there's
Meredith, do you care to share your thoughts with us?
I'm sorry, what was the question?
So even if we didn't have a title on that little clip, you would have been able to identify that Meredith was somehow distracted, disinterested, not paying attention. What do you think what's your next sort of go-to move as the sort of instructor in this situation? Right. Yeah, just sort of.
I mean, it normalizes participation. So
Right.
Your expectation that you're going to contribute in some way.
Sure, and so this may just be a matter of, sort of regaining the learner's kind of attention. Yeah. Other thoughts? No, I think. Are there other specific techniques that you might think about using, like going back to the sort of toolbox that we've put together? Are there specific things that might be helpful, either in the moment or after the fact?
Reading through these, if they're disengaged, that's probably not going to catch their attention. But maybe naming the dynamic after the fact would be helpful for the next time.
So you don't really know why they're disengaged. You just know that they are, right? And so, so maybe there's an after-the-fact opportunity to ask them, check in with them, right? This might be a check-in moment. Is everything okay? Are you looking at your phone because you're a fourth-year student and you're waiting for like interview invitations, and if you don't respond in 37 seconds, you lose your chance? That's a real scenario, and like that's real life. Or are you like swiping Tinder? I don't know. So it's probably a reasonable opportunity to ask questions.
Yeah, so there's also an opportunity for previewing here when you're in this kind of situation. If you realize someone might be disconnected or disengaged, once you realize that's occurring, you can even let people know that you're going to start asking questions, which will give them an opportunity to come back to the discussion and participate a bit more without it seeming like a blindside. For example, one recommendation here might be to simply say, I'm going to ask everyone a different question in turn to get everybody involved. I'll start with person X. And you would begin with the person who wasn't the disengaged learner. That way they'd have some time to come back to everything without feeling embarrassed or ashamed, but realize that that their participation is still expected.
Great.
All right, any other thoughts before we move on to our next one? Fred, where'd you click last time?
Fred, do you mind if we chat for a few minutes? I always like to debrief procedures with medical students after we do them.
Okay, sure.
How do you feel that lap repair went?
I think it went pretty well. I've done a few lacerations now. That one seemed to go pretty smoothly.
Yeah, I think that the suturing and numbing up the wound went really well, but I'm a little concerned that you didn't really seem to clean out the wound before you closed it up.
Well, what do you mean?
I noticed that you jumped right into numbing it up and suturing, but didn't really take the time to clean it out well, which, especially if a wound is dirty, can raise the risk of infection.
I mean, the wound didn't look that dirty to me. Plus, it can't make that much of a difference whether you clean it out or not, right? I feel like we get so much criticism as medical students. I mean, the other residents that I work with, they barely clean these wounds out when they do these lacerations.
So what's our take on this learner?
We're about all of our residents, frankly.
Right. So you're concerned, right, though, that their role modeling has not been great, and so. Right. How about specific to this interaction? What are your concerns here?
Yeah, I feel like this is another common one where I think when I'm at my best and most empathetic, I can like really see that like the defensiveness often comes from like being really scared. And especially for like a medical student or an intern, of like that real feeling of like I need to prove myself, so I'm gonna automatically be defensive. So I do, I think it's on the next slide, but I do try and be like, you know, like I will like step back from what we're doing and be like, I know it's like really hard to be this person, but like you are here to learn, and like I want you to learn, and like learning means not knowing all the answers. You shouldn't know all the answers, or else you'd be doing my job. Not my job, actually. I don't know a lot of the answers, but so like let's, you know, talk through it again or whatever, and try and like reset your dynamic.
So in that case, you're stepping away from the specifics of the case and thinking and speaking more to the sort of that what might be having that, yeah, sort of working on that relationship building.
You can also kind of help them to understand that this is a common problem and not unique to them, that they learn things incorrectly from the residents, and kind of challenge them to question the resident when they're doing things. You know, you see this all the time. The students watch the residents reflexly order a CBC and a chemistry on every single patient, and then they can't justify why they're ordering it. So I just say, you know, this is a really frequent problem. Even the residents do it. My challenge to you is anytime you see a resident do a procedure, write an order, whatever, ask them why and see what the answer is and see if it makes sense.
I love that, because you just did like 3 of those things, right? You validated their frustration with seeing things done in a way without thinking. You normalized it as like part of their thing, and then you broadened it to say, when you see this again, I challenge you to sort of apply this to other situations, not just this laceration repair.
I think the other thing, if you know you have a defensive learner, because you know the defensive learners, it's not a one-time thing. It's repeated behavior over and over. And if you know you have somebody that's defensive learner, every time you have one of these interactions, I think you try to normalize it and say, you know, not everybody has things that they can work on. This is one of the things you can work on. Let's talk about it. And you know, you're not the only one who's had this situation happen. Let's talk about it and kind of normalize it, that everybody has to have this. And if you know they're a defensive learner and you can preface it that way before you even get into the specifics, I think a lot of times that can help.
Yeah, because all of these techniques don't negate the fact that you need to address the specifics, right? Like you need to get them there, but you need to get them in a place where they're going to hear what you had to say.
I've had some issues with that very thing where I've had a couple of residents that are consistently defensive, and I keep getting feedback from off-service attendings that it's a problem, and I have to bring them in and counsel them on it. And one thing I've found really effective, because generally maybe they're scared, but a lot of them just want to be right, and so they don't like to be wrong, and so they are defensive. And so I do like this role-playing thing where I have them correct me on something, and I give a defensive answer to it, and then I have them do it again, and then I go, okay, gotcha. And I say, you know, and they feel like how much more confident the okay, gotcha comes across than me, you know, disagreeing with their correction. And they like, one of them really just like had an aha moment with that role play.
Love that. That's like sort of demonstrating for the learner what it's like mirroring back what their response looks like to someone else. Can be really powerful. And I think it all gets back to that sort of like growth mindset, right? Like it's not about being right anymore. I mean, it is a little, but it's really like we're all wrong a lot, and it's about learning how to be wrong.
In my med school, this was a big problem because there was a strong sense that we were not allowed to say when we didn't know something. And this was passed down from generation of class to generation of class. And, you know, if you didn't know, you could never admit that. You always had to give an answer. Because if you didn't, you weren't going to get an honors, and then you weren't going to match into whatever you wanted to, and then your life was going to be over, and then you'd be stuck with $300,000 of loan debt and no job, and the spiral continues. And I remember finding that very problematic, that sort of mentality was there. And it seemed like it was actually really there. I remember rotating and feeling as though I could not say that I didn't know something if I were being quizzed or grilled by an attending, especially on certain services. And I distinctly remember one person standing 6 inches from my face while asking me to answer things so that I couldn't look down at anything and reference anything. Anymore, that would violate social distancing rules, but back then it was still all right. And I remember vowing that when I was in that same position, I would not make people feel the same way. And I often begin shifts by saying, just to set the tone, it's a previewing that I use for almost every shift that I'm on. I'll say to the medical students and the residents that I'm with, it is always okay to say to me, I don't know, I'm not sure, I need help, I'm scared, can you explain to me this? Because I don't know everything, nor can I possibly, and I still look things up, and that's completely 100% okay. It's not expected that you're going to know everything, it's expected though that you will be here to learn. And I've had great luck with that anyway, and if I forget to say it at the start of the shift, I say it as soon as someone demonstrates a characteristic that might fall within one of these learner types. That way it reframes the shift and sets the stage and the expectation. So it's a way that I tend to use previewing and also normalization, because people do often feel like they can't say when they don't know something in our line of work, and that they have to be able to establish and defend whatever they did, and if they don't, then they're a failure, which is completely unhealthy and toxic. But we can do things to help it change with small steps like this. Sure. All right, so summary of the defensive learner. It's challenging to be in the role of a medical student. I haven't forgotten what it was like. It's important to recognize your mistakes so you can learn from them. It's how I got to where I am now. So normalization in a big way there. Fred.
Pass it on to the digital native.
What the heck? You gotta move the arrow
Very
first.
strong work. That was a difficult case and a really sick patient. So I thought it might be helpful if we debrief a little bit. Maybe one of you could share with me how you begin to manage DKA in the emergency department.
Well, for this case,
This is easy. This patient's sugar is high because they're not taking their meds.
I'm not sure I agree.
Let's take a step back and sort of talk about what you might order first and how you might begin the workup.
Yeah, so usually I start with fluid boluses and
No.
then
So I start with the fluid bolus and I just start the insulin right away. I just want to get their sugar down as fast as possible.
don't you have to check their potassium first?
No, I've never had that change my management. I just start the fluids, I start the insulin, get their sugar down as fast as possible, get them admitted. The faster it's down, the faster they get admitted.
Never had any learners like that. Josh King. Sorry. This is a tough one, right? What's your next move in this situation? Yeah. All right, Mello.
I do feel like you have to let that person know that they are wrong, because if you don't, they're just going to keep believing that they're right, and that's just going to lead to worse patient outcomes and care.
Yeah, there's definitely there are times when you have to be sort of a little bit directive. How do you help this person?
I think one of the things that you can kind of try to spin it so maybe they realize that at times they might be right, but that at times they are wrong. So in this particular case, something like, well, if the sugar is 800, you probably are okay starting the insulin right away. But in cases where the sugar is lower, you may need to check the potassium first, and kind of make it so they realize that there is more than one way to skin a cat, and there may be more ways to do things and maybe their way is not the only way.
Yeah, I think that's one of those, like, there's rarely a right and a wrong, even when there's a my way, right? Yeah.
I don't know if this is the best way to do it, but you need to correct them. Like, there is a fundamental lack of knowledge, and they can harm someone. And so I don't know. It's probably helpful to like ask you a question like, oh, potassium doesn't change your management. Well, what if? Like ask them that question. Like, what if their potassium is 2.8, and then what? And then try to have them stumble upon like, oh, maybe I'm overconfident this happened. I don't know if we'll hit that insight necessarily because I feel like the confidence like domineers it sometimes, but it maybe is a way of addressing that like knowledge gap because it has to be addressed. Otherwise, there's risk of harm.
Yeah, it's an important distinction to make, right? Like you absolutely have to address it, and it's a question of like, what's the way?
I mean, in this case, you have someone that has insight that's not domineering that you can use. You can say, okay, so and so is saying that the potassium is important, and you're saying that it is not important. So I'm going to ask her, why is the potassium important? And then you still have the Socratic kind of learning, and you're not dictating. And then when they summarize something, you can say, I absolutely agree with this. The potassium is very important for those reasons.
Yeah, absolutely. In this case, you have sort of a foil, right? Like you've got someone you can play off of, and if you didn't, then you might then your sort of take on it might be.
Yeah, I feel like I take it when you don't use the foil or someone else to engage, like you have the risk of disconnecting from them and like having them close off more like in their assumptions. Like it's hard because you can't confront it directly, and it's better to use other methods like foil or someone else to raise that point.
And sometimes I think when they just aren't getting it, you just have to say, you're wrong. And just say, go, or the other thing you can also do is tell them to go look it up. Go look up some clinical guidelines, and I want you to report them back to me. And sometimes they'll figure out that, oops, I looked at the wrong thing, or I looked at the wrong guideline. So, but every once in a while you'll have somebody that you're just going to have to say, you're wrong. Period.
Since you guys are the experts. No, this is the learner I struggle with the most, especially because it's so often paired with the defensive.
Right.
Mm-hmm.
And, especially every once in a while you'll get someone who you work with over time who maintains this learning style with defensive. And I find I just tighten the leash more and more and more because they're so obliviously wrong constantly that I'm like, you are going to do harm. But then they really chafe with that often when I'm like, I really need you to like run your plans by me before you do them. I know you don't usually have to do that in the adult emergency department, but here in the pediatric emergency department, I'm going to need you to tell me what you're going to do before you do it. And it just gets like tougher and tougher. So I want to learn how to fix that.
It's a struggle, right? And this is, as somebody said before, this is often not a one-off kind of situation, right? I don't have a ready answer necessarily, apart from everything we can do to lead the person to that realization or force them into that realization. And it's tough. It is. It's a real challenge. Other thoughts about this specific instance?
It really is a tough one. I oftentimes lie in this situation. I know that may not be the most ethical thing. Well, let me tell you what I mean. So let's talk about what, yeah, right. Let's talk about what I mean by that, because it's really tough when you're in a situation like this and you're faced with someone who not only has obvious knowledge gaps but lacks insight that they have those knowledge gaps and lacks insight as to how they're being perceived in a situation where their knowledge gaps could actually kill somebody. And this does happen. The lie I often tell goes kind of like this, and it has to do with trying to defuse the situation with validation and normalization. Whether it ever works, I'm really not sure. But I'll often say, what you're describing right now is something that I went through as well, or that we all went through, and that's the soft lie. That's I one time made this mistake when I was managing this case too, even if I never actually made that mistake, because that at least makes the person feel like I'm not judging, I've been in your shoes as well at some point in time. Choose your words of the statement however you will, but like, if we begin it with, I remember a couple of years ago, I had a case of DKA like this as well. And I avoid saying things like, when I was in your shoes, or when I was a blank, because that casts a paternalistic type situation, and that doesn't help you maintain educational alliance. So more so, I remember when I had a situation like this a few years ago. The patient had this, and I did this because I used to think that I could manage it in that way as well. And here's what happened, and here's what I learned from it. And I'm concerned that with what you just shared with me, that you might wind up making the same mistake that I did. And I don't want to see that happen because I'm looking out for your education and for the patient at the same time. I have a hard time seeing how, in those words and in that way, someone would be terribly upset with you for giving them constructive feedback.
I felt the same way. Now that you name it, exactly. Or like, from one of our peers or someone like who made that mistake, and I just like say, oh, I made that mistake, and use it as a teaching moment. It
Right.
normalizes it, validates it, it makes it more real. That like you as their teacher, instructor, like the person who's supposed to know all is valuable.
Right.
I'm a liar too. It's fine.
Yeah.
I think that last part of what you said is sometimes can be implicit. The like, I don't want to see you make the same mistake, and it's about reading the situation. And sometimes it needs to be like explicit, like you're gonna hurt someone, and I don't want you to do that. And it's a little bit of a like, where are we on the spectrum of?
It gives you the window to name the mistake they're about to make.
Right.
And like put it out there very explicit terms. Like the SAEM in this particular instance, you can explicitly say, here is that knowledge point. Don't make that mistake.
Yeah, I think.
Normalizes it, teaches them.
As a medical student, I believe in hindsight, I've been told that lie.
It's sometimes not a lie.
Yeah. Right. Yeah.
And I feel like it does actually, that does work, and it does, I feel like, build like empathy and connection more. Like as a medical student, I feel like, okay, this doctor did that same thing. So like, now I actually just need to do what he did, and I'll be in the clear and all good. So I feel like that actually, as a medical student, I feel that works.
Yeah, and it's a way of broadening your exposure to the range of possible experiences, right? So this learner has never had the potassium change in management BK yet, right? But
it will
by
shortly.
Sharing that example, by sharing that example, I've now, at least sort of in a hypothetical way, broadened that learner's exposure to different ranges within that, and hopefully in a way that sticks a little bit, in a way that makes them feel not outcast.
Great. All right, so we have about 6 minutes left in our session. We have one more case to do, and I think we have time to get it done.
As long as Fred wins.
Yeah, as long as I don't click. Fred remembers when he clicked the wrong place many times.
Hey, Andy, I was sensing some frustration. Do you want to take a minute to debrief that case?
I mean, sure.
Okay. So I know that was really challenging, but can I just get your initial thoughts?
I mean, I'm just so tired of this. I am over this. I'm so sick of taking care of all of these unvaccinated COVID patients. I can't take care of one more of them.
I feel very, very similarly. It's very frustrating.
I mean, really, what am I supposed to do? I'm sitting here putting myself and my family at risk. So what? They can just go upstairs and die in the ICU?
It's really, really hard.
I mean, what am I supposed to do? You know, I try, I give myself to this job, and for what? For what? Thanks. Here we are, every single day, same thing again and again. I've got other patients I could be taking care of. I have other families I need to be talking with.
I don't know if anybody feels that way sometimes. No idea. What's your go-to move here?
I think validating that their feelings are real is the biggest thing, and say, you know, and you know, that we all have these types of feelings, and it's okay to feel it, but that we have to move on or we'll be stuck forever. And you know, and it's another one of normalizing it and saying, I have these feelings, you know, I agree, but I have to, you know, we still have a job to do. We still have something that we've sworn we're going to do when we took our oath. And so, you know, we just have to figure out how to move on. And do you need a few minutes to step away and come back when you're ready? And I think that's one of the biggest things, is letting that person step away for a minute, particularly if they have a death or a hard case, or, you know, they're pregnant and they just took care of a kid who died or something like that, or a kid who's really sick, and, you know, acknowledging that it's okay to be human. So.
I think that's really crucial, right? And even going so far as to sort of just saying it out loud, like, you seem blank, right? Like naming this dynamic, like you seem upset, you seem frustrated.
Yeah, I'm upset. What? I don't need a minute. What I need is for people to get their COVID vaccines.
No, you need maybe 5 minutes. Other thoughts about this particular case with regard to the emotional learner?
I was in another session where they were warning you kind of against interpreting people's objective actions. So you'd say, like, I saw you throwing papers and kind of pacing the room, and it seemed to me like you were frustrated, but what was going on? What was happening? You know, like, not actually interpreting, like, without an exit, so that they can, you know, otherwise they'll get defensive. I wasn't frustrated, you know.
No, I think that's a really, really good way of approaching that, and I appreciate that because it's not painting them into a corner. They're either frustrated or they're defensive about not being frustrated. Whereas what you've just said, I've observed this. This is something I've seen. This is my interpretation, and leaving it open to potential other interpretations. Really important.
Yeah, fun tip that I've picked up from being in a relationship with my wife for 12 years. If we get into any sort of disagreement or discussion about something, we conscientiously use expressions that begin with I as opposed to expressions that begin with you, which actually makes a big difference both in that dynamic and also it works in many other circumstances as well. So something like this, you know, you seem frustrated, you seem angry, you know, seems accusatory and presumptive on the part of the person who's trying to help, as well-intentioned as that may be. Whereas, you know, I'm sensing this. Can you tell me if I'm sensing that correctly? It really makes, it diffuses the entire situation and it allows people to remain open as opposed to feeling judged. Any other thoughts from anyone on that case? All right, guys. Well, thank you for attending this. So, you know, hopefully this has been useful. And in summary, keep in mind that, you know, a lot of communication strategies can be used to help you when working with challenging learners in the department. We tried to provide you, you know, some useful ones on this sheet here. But there's obviously a lot more that goes into this than just this. But hopefully this would be a good start. If anyone has any thoughts in closing thoughts for the group, please share. Otherwise, thank you everyone for coming, and we wish you the best of luck in teaching in the department.